Hello, everyone, and welcome to the November learning session for the Pediatric Readiness Quality Collaborative. We have a host of presenters this afternoon or morning. We have the PRQC admin team, we have members of the NEDARC team, and then we have team updates from 4 of our teams. That would be Team 3, 12, 13, and 14. As a reminder, the information that you'll see on today's presentation should not be construed as the official position or policy of the entities that are listed here. So what we'll do is go ahead and get started with roll call, and we ask that you go ahead and use that chat feature on the WebEx platform and just enter your name and let us know what hospital you're from. If you're from Team 1 from Alaska, go ahead and enter your contact information and welcome. How about the Lifesavers? Welcome this morning. Team 3, MoCan Rocks. We will actually have a team update from that team this morning, and so we welcome you. Team 4, the Longhorn Kids. Team 5 is the North Texas Division of HCA. Team 6 is the Fight or Flight Response Team coming from California. We have the New England EMSC team. The 8 is enough. Team 9, Red Tea for Kids in Georgia. We have the Pit Crew, Team 10 from Indiana. The Remock Minions from Illinois. The Whisper team, which we'll hear an update from today. We have Wrangler for Kids, Team 13, which will also be giving us an update. Team 14, the Oregon Pediatric Readiness Program. We have an update scheduled from them. For Team 15, we have ETCH, and lastly, Team 16, we have the Pediatric Peaches. And so welcome, everyone. Don't forget that we are offering CNE and CME credit for today's session. What I'll do is in the chat button, you'll see that I am clicking the link, so it'll be available for you all to request credit for today's session. So here are our talking points. We will get an update on data use agreements from Eddie Zamora. There will be time to discuss some of the intervention bundle updates that we'll be rolling out in the next 2 weeks. There will be time for Patty Schmuel and Mike Ely from NEDARC to talk about the data entry system. We'll have team updates, which will take about 40 minutes, and we'll keep some time for you to ask questions for these specific teams, and then at the sort of last 10 minutes, I will give some housekeeping items. So now we'll start with the PRQC updates. Eddie, are you on the line?
Yes, I am. Thank you.
Great.
Good morning, good afternoon, everyone. So we showed this snapshot in one of our last learning collaboratives, so we thought we would share it again. At the moment, we have about a third of data use agreements that have been fully executed. We have about 10% that are in the signature phase. So either party has, either both parties have signed or they are signing, and they'll be fully executed in the next week or two. And then about another third are in negotiation. These are data use agreements which are in which the legal language is still being figured out, or one side is still kind of determining what their needs are for their site. And finally, we have about 31%, which I would say are in the other category. About half of those, I'm not sure what their status is. That means that I have not heard from them. I'm not sure how far along they are. And about the other half of that other really has informed either myself or one of their team leads that they are kind of working on their DUAs. So that's kind of our breakdown. And that includes about 135 DUAs that we're moving forward. And I'll in the next slide. Can I move it? Yes. Okay. In the next slide, these are the sites that have been fully executed, just for your reference. Next slide. These are the DUAs which are in the signature phase. If you look at the left column, those are single sites, and if you look at the right column, that's a network site. So Providence has submitted a DUA with signatures, and we're just waiting for one more signature, and we can send it their way. I was told that we probably could have it this week. So Providence, great job. You'll be fully executed very soon. Next slide, please. These are the DUAs that I would say are in negotiation. The two left columns are probably single sites. That middle column is the Ascension Seton network. So we're working with both the legal team and the IT team and kind of coming to some agreement on that agreement. So that's going to be a national DUA. It might include some other sites, so those are the ones that I'm pretty sure are going to be included in the network DUA. The one on the right is Medical City. Again, we have sent over the DUA with red lines to that site, and kind of we're waiting to hear back to move that forward. Again, it's a process. It takes a bit, some conversations, and takes some coordination sometimes. But if you ever need clarification on where we are, reach out to me. Sometimes I don't respond right away because I need to look at my notes and be able to respond appropriately. Finally, we have the other. That's that 30% of sites that we have some information, but really would need some support. And in the latest report that we sent out to the team leads, I kind of identified those sites. And we can talk more about how to support these. I know that I've spoken to Erica Kane a little bit about maybe EIC or NEDARC reaching out to some of these sites and having some conversations with them to kind of support them. Sometimes it's just a bit of education on what we're actually doing, or a reminder. In some instances, it's like, oh, I thought I had submitted that, but really it's just about like reminding them that we still need that information. And again, we'll keep producing these biweekly DUA status reports. They seem to be helpful in kind of informing both the admin team as well as the teams. And as questions arise, you can reach out to me. I have been out the last week and a half, so if you have reached out with questions, pardon the delay, and we'll get back to you shortly. You can always also reach out to Crystal or Terry as questions arise. Any questions for me?
Yes, Eddie, we have one question. So one of our participants noticed that there are a lot of SSM Health sites. Is it possible that they could have a national DUA established?
I remember that in the past there was a conversation, but it was never. My understanding was that they were going to go through a single site DUA. But we can find out if they are trying to pursue a network DUA, because there is many. If you go back to the fully executed slide, and let me see. So some of the SSMs have completed a single DUA, which is why I felt that they were probably going to not do a network DUA. We have SSM Health, Cardinal Glennon, and St. Clair. So yeah, so my understanding is they're not pursuing a network DUA at this point.
Okay. Any other questions for Eddie regarding data use agreements? Okay, thanks, Eddie.
Thank you, Chris.
Now we will have updates on the intervention bundles.
So this is Kate Remick. So good morning or afternoon to everyone. So there's been a number of questions that have come up regarding selection of the intervention bundles and how best to do that. And so we just wanted to be able to provide a brief overview to everyone and just make sure that we're all on the same page. So as you all are aware, one of the initial requirements for this collaborative was being able to actually complete the pediatric readiness assessment. And this gives you an overall score, of course, for readiness. But relative to the 4 bundles that are included in this collaborative, it really only asks essentially one question per bundle. So, do you have a process for assessing pediatric vital signs and notifying physicians? Do you have a way of measuring children in kilograms only? But it doesn't really get into the details of that. So the whole purpose of the environmental scan, which we are calling step 2, is really to hone in on the specific gaps or details relative to each of those. So it really expands those single questions that you see in the PEDS readiness assessment to identify opportunities to intervene or where your change strategies could be focused. So the environmental scan will ask questions about, where children are weighed, how they're being weighed, so that you can really walk through it and get a sense of the entire process around each of those intervention bundles. So it really helps you to dive a little bit deeper into that intervention. It's not a repeat of the pediatric readiness assessment. It does not have a score associated with it. This is entirely for you so that you can walk yourself through that process and say, okay, these are some gaps here and these are gaps relative to this bundle versus that bundle. And this really can help you to better understand where the gaps might exist across all 4 of the bundles, so you can really make a better guess at which bundles might be more advantageous for your focus throughout this collaborative. The next step really would be collecting some baseline data. So the baseline data allows you to actually look at or measure your performance using those quality metrics that have been identified in each of those bundles. So you can enter baseline data for all 4 of the intervention bundles at any point if you want. If you're certain that there's a lot of gaps relative to 1 or 2 of the bundles that you've selected, then it's fine to just enter baseline data on those 1 or 2 bundles. But this gives you a starting point upon which to grow or to improve. The importance of having that baseline data is because this really can serve as a talking point to your group of stakeholders at the local level. So you can take that baseline data and performance back to your local leadership teams or admin teams and explain to them how we're doing, how you compare to other sites within the collaborative, and where the gaps might be. And that allows you to really get further buy-in or support to be able to implement those change strategies. So we really view this as a 3 to 4 step process depending on how you look at this. But the PEDS Ready assessment is very superficial in terms of looking into each of these intervention bundles. Step 2 gets you into a little more depth, and then of course 3 and 4 really being able to measure your performance. If you'll go to the next slide, Crystal. So within each of the bundles, we've been working on trying to make things a little bit easier for you all, and the NEDARC team has come up with drafting a paper version of Bundle 1, which is the weight in kilos. And the benefit of this is that it'll really walk you through what all is being asked of in terms of variables. So, Mike, I'm going to pass the floor over to you so that you can speak about this.
Terrific. Thanks, Kate. And good morning, good afternoon, everybody. Nice to be on the call with everyone. So, as Kate mentioned, we drafted up a paper version of the Bundle 1, which is the weight in kilos, and we'll also be doing this for Bundles 2 and 3, so that you can basically this document, and we'll scroll through it here so you can kind of get a visual of it. It really serves 3 purposes. One is it allows you to see, what specific data elements and data variables are going to need to be collected for both baseline data and for the, once you get into PDSA cycles, so that you can, get an idea of, if you take this document and go to your electronic health record and just have an idea of what needs to be collected and where you find that in your own electronic health records. So you can have an idea of, if the information is in one area, if you're going to have to go to multiple spots in your electronic health record. So that will give you, an idea of how that process will work. Secondly, we want this to, obviously to see the actual flow of the data entry system and see how it's going to look with the skip logic and everything, so that, it will look a little bit different in the actual data system, because certain questions won't become visible unless you answer yes to the previous question, for example. But in this document, you'll see arrows that signify the skip logic that you'll see in the data entry system. And third, you could actually, if you're really ambitious, you could actually start collecting your baseline data now with this, using one of these forms for each patient record, and then having that information so it's ready to be entered into the data system once the data system is ready for use. I know that means you'll be basically recording information twice, so you don't have to do it that way, but it's certainly an option. So this you'll see here these little section headings like site procedures and guidelines and common vital signs for bundles 1 and 2. That's actually how you'll see it in the data entry system. So for instance, question 7. Now it won't be marked question 7 in the data entry system, but we're doing it this way so you can see the flow. The question is, what's the weight in the medical record? Was there a weight recorded in the medical record? Yes or no? If you answer no, then you don't see question 8. You go straight to question 9. But if you answer yes, then a box pops up about what was the weight measurement unit. Was it kilos, pounds, or both? And depending on which selection you make there, you'll put in the weight in whether it's kilos only, pounds only, or both. You'll see here anything that's in italics means that that's a rule or a range or something that you have to, like for instance, you can only enter between 0 and 200 kilograms. So if you enter something outside of that, you're going to eventually get an error message. So anything in italics in this document is sort of a rule or a guide for what needs to be entered into that data variable. Medications administered, again, if you say yes, then a whole list of medications pops up and asks which medications were administered. When you click on any one of those medications, for example, Decadron, then you'll get a subsequent box which asks for the dosage, which will have to be between 0 and 100 milligrams, and then the route that it was administered. But you won't see any of that until you actually answer yes, we gave medications, and then which medication, and then you'll see the dosage and the route. So the form kind of expands depending on how you answer the questions. Then basically the bottom looks like what you'll see in the data entry system. You'll be able to save your work with the blue button. It's very important that you actually save your work. You click on that button, frequently, because your work is not being saved automatically. So if you actually get pulled away for some emergency and you're entering something, if you haven't saved your work, the system will time out after a while and you'll lose it. So you really want to save your work. We'll have reminders of that in the training manual. Once you save your work, then you have the option of going back to the workbench, completing the selected record, or removing the record if for some reason it's an error. You'll be able to save the record without any problem, even with incomplete fields. But when you actually go to complete the record, that's when you'll get error messages, if there are any errors, if you haven't filled in fields that are required, or if you are if a value you've put in is out of range. So you'll get error messages at that point. But anyway, that's an overall view of Bundle 1. We'll be creating this again for Bundles 2 and 3. Hopefully those will be ready by the end of the month. So hope that helps just to see a visual of kind of how the data system will work.
So Mike, really quick, can you reinforce that question about for the medications that are given, and if something's out of range, how will the data entry individual know that the dosage out of range?
So the first thing you'll know is you'll see, when you click yes, medications were administered, then that whole list of medications that you see in this little table here will pop up, and you'll click on the medication that actually was administered. So say it's ibuprofen and morphine. Then you'll have boxes that pop up below those that say how much ibuprofen was given and what was the route, and how much morphine was given and what was the route. And in the dosage, you'll see that between 0 and 100 milligrams that's the range that you have to operate within. So that's your first visual or first clue. Actually, you'll see this in it'll also be part. You'll see this this document to be part of the training manual. But that would be your first visual in the data system when you're actually putting in information. So if you put in a range or a dosage that's within the range, you'll be fine. If you don't, when you go to the bottom to after you've saved the record and hit complete selected record, you will get an error message. You'll actually get an error message for every field that there's a potential error, or there's a range that you have to operate within, or a field that's required. You'll get a little a visual at the top that will tell you there's a medication rule error, for example.
Mike, there was also a question that was asked in the chat box by one of our trainers regarding how do we know whether or not the dose was appropriate, so I just wanted to comment on that. And so all of these medications were chosen because they have fairly standard dose ranges that are used across the board. And so those are being used to calculate the possibility of dose error. So that's being done on the back end and will be displayed through the quality metrics that are listed and will then appear on the dashboard. So, you know, it can certainly be calculated by the champion themselves, but the entire data entry system will be doing that on the back end so that it's then displayed on the dashboard as whether or not that medication was appropriate. Hopefully that answers that question. All right. Crystal, do you want to go back to the next slides?
Sure.
And just as a reminder, you know, if you do have any questions, remember that everybody is on mute. So please do go ahead and enter any questions into the chat box as they come up. So I'm going to turn the mic over to Diana Fenja, who's going to talk a little bit about the resources available for interfacility transfers.
Good morning and welcome again, or good afternoon, depending on where you are. We are very excited that some new resources that will be essential as folks move forward with the interfacility transfer intervention bundle are now nearing completion for insertion into box and to be posted on the website, which will be discussed a little bit later. But the family evaluation form is complete. The interfacility transfer feedback form, there are a couple of those that could be used as templates and adapted to your own organization, and specific content that would be essential for a transfer packet for families who have children who are being transferred to additional resources will also be available very shortly. These new resources were developed by EIIC and our subject matter experts and our partners AAP, ACEP, and ENA. So I think that they should be very helpful to all of you because some of the content on each of those will be essential for our data entry in the future. And that's it for interfacility transfer. So look forward to seeing these new tools being available.
Great, thanks, Diana. With respect to the disaster bundle, as everyone knows, we broke this bundle up into phases 1 and 2. With the launch now being postponed, I just want to make sure it's clear that we're going to start by working on domains 1 through 4. For those of you who choose this bundle, so pediatric disaster coordination, coalition building, both locally and regionally or either one, pediatric surge capacity local and or regional, and then essential PEDS resources. Phase 2, which will focus on domains 5 through 7, triage, decontamination, and tracking and reunification. Those will launch later in 2019, in the summer of 2019. So for those of you who will be working on disaster, you can prepare for that timeline. Crystal, would you like to speak about the bundle selection that we have so far?
Sure. So we've asked sites to go ahead and start submitting their QI data stewards, and on that survey we have a specific question about declaring your intervention bundle. And so at this point, here's a snapshot of the first and second choice that most sites have selected. So you'll notice that for the first choice, Bundle 2 abnormal vital signs has been selected by 12 sites, with the next bundle being weight in kilos being the next preferred bundle. And then for option 2, you'll see that weight in kilos and abnormal vital signs are still those high-ranking selections for the intervention bundle. We are giving all of our hospitals the option that after they've made some substantial progress on one of the bundles, that they do go ahead and start working on a second bundle. So that will be your option, and so that's why we're asking for your first and second choice.
And so remember that those are asked on the environmental scan. So it's really after you work through the environmental scan and understand the processes surrounding each of these interventions that you'll be more informed and able to choose maybe your top-ranking bundles. You do not have to, fully 100% commit to this, no changes possible. But we'd like to at least try to get a sense so that we can better support you all in your various groups and really understand the metrics around that. So if you can at least try to give us the best ranking that you know how to after you finish that environmental scan, the more we can help you. We proposed just a couple questions here that we thought folks might be wondering about. One is how should the paper survey be used, and we are working on creating these for bundles 2, 3, and 4 as well, so that you all can work through these. Really the goal of this is that, over the next couple months you can begin to develop your chart sampling method. So we talked about this a little bit at the last learning session. For example, if you're looking at all pediatric patients that come in or those that are more critically ill, you may be filtering through so that you're just focused on, for Bundle 1, all PEDS patients. For Bundle 2, maybe those that have higher triage categories. For Bundle 3, really those patients that are being transferred. But depending on your numbers, in other words, your pediatric ED annual volume, you may choose every single chart because you need those to be able to really assess, or you may break it down by maybe every 3rd chart or every 5th chart, and so how you begin to sample around that. The next piece is really being able to use that paper survey so that you can map it to the variables that are in your electronic medical record, or if your site still uses some version of paper records that gets scanned into a computer system. But this really allows you to map it out so you know where to look. As Mike mentioned, if you'd like to, you can begin to you could print out multiple versions of that paper survey, which are now on Box, and you could actually go ahead and enter in all that information and then transcribe it to the data entry system once it opens. But that wasn't really the initial intention. It's really just so that you know where to find the variables in your EMR and so that you're ready to go when the data entry site goes live. The other piece that we think would be helpful is to go ahead and develop a method for maintaining your own internal records. So as you all know, the actual patient medical record is not being entered into the data entry system. Every chart that you enter has a randomly generated system patient number. And so the only way that you'll be able to go back and finish charting on a patient is if you have a spreadsheet or a way of maintaining that linkage to your records on site. And so our recommendation is that every site think about how they maintain a spreadsheet that has the system-generated patient number and your local medical record number, and that will only be for your purposes. And then the last piece, of course, is that if you do end up writing on these paper surveys or maintaining these spreadsheets, just making sure that you're holding those in a confidential location based on the requirements of your institution. And then on the next slide, we proposed an alternative question as well, which is, are you suggesting that we collect baseline data on, both of these intervention bundles, for example, weight and kilos and abnormal vital signs, before we formally declare a bundle? And do we enter all of that data in the portal? So again, the answer is you are welcome to. If your site and the leadership or stakeholder group at your site is, wavering between which bundle to do, sometimes that baseline data can really push you in one direction or another. If you're not getting a lot of support, sometimes it's nice to just have an easy win. So maybe your performance is pretty good at the beginning and you can make some very small changes or interventions at your site to get to 100% on the various metrics. And that's great. That's a great way to get buy-in. But maybe alternatively, your site is really excited about pediatric readiness. So you might choose a bundle where your baseline data demonstrates poor performance overall, and this is a real opportunity for impact. So you're welcome to enter baseline data for any and all of the bundles. You'll, of course, be able to review the dashboards for each of the quality metrics so that you can see how you are performing or your site is performing and how you trend as you move forward with this collaborative. And it'll really help you to create ongoing SMART aims as you move through the various PDSA cycles. And then, we're aiming at this point, as you'll see with our upcoming timeline, that the portal will be open no later than January 2019. And the paper version, of course, is available now if you do want to go ahead and start doing any of that baseline data collection. So I'll turn the floor back over to you, Crystal. Thanks.
All right, so now what we'll do is discuss the data entry system. Mike, you want to talk about the remaining steps and anticipated timeline?
Sure, thanks. So we on the October 2nd call, we put the timeline. We've adjusted it a little bit based on where we're at, but we'll go through these steps. So we've done a clinical review of the data entry system and all the variables to be collected, and made some changes based on that. Those modifications are now being, most of them have been done. We're doing a couple of more really related to bundles 2 and 3, related to some information on the ICD-10 codes and patient diagnoses, and how we're going to be putting that into the data system. Those modifications are being made. The whole time throughout this, we've been continuing to test internally, and when we find things, we submit those to our IT team. So we'll continue to do that. The plan is to get to the system to Kate and Crystal for their testing at the end, towards the end of this month and into early December. They've actually been we have weekly calls with them, and we've shared our screens with them, so they see the system, they know how it's working, but it actually gets them so they can be testing it themselves. That's for the end of November into early December. Modifications will be made based on that in early December. It's a little bit hard to know if what modifications will need to be made. Our hope is, of course, that we'll have identified any major issues on the front end with the internal testing, but there'll be a block of time for modifications to be addressed. Then in December, we'll be looking for field testing with a few pilot hospitals. We've identified, through the survey that the EIC has put out, several hospitals that were willing to be pilot tests, so we can do that process in December. Again, we'll have modifications probably that come out of that. Now, and when I say modifications, it's there's some things that, as we find, that need to be fixed, what we call bugs, that prevent the user from going forward, or if it's a problem with saving a record or anything like that, those things need to be fixed. There's a whole other category of things that we might call things that are nice to have, but don't actually prevent the system from being used and from data from being entered. We separate those, obviously, so we're correcting the bugs first, and then the nice to have things we'll kind of put out for later fixes, and we'll release different versions of this as we get to those. Then the plan would be for an initial rollout in January of 2019. As you're going to see here, we're also developing a training manual, which we've been working on since October, and Patty's going to go through the outline for that. So we'll continue to work on the training manual, and then dashboards as well, which are going to be how you can see the information that gets used in the data entry system, that goes to a dashboard to see how you're doing with PDSA cycles and so forth. A couple of other things that aren't actually on the screen. We have to create Active Directory accounts for each user in every hospital, and there's we've allowed up to 2 users per hospital. We've gotten the results back from 21 hospitals, I think, on who those users are. So we're working with our IT staff now to start the process of developing these Active Directory accounts, and there's a process for that. so that you'll actually be able to, access the system, both the data entry system and the dashboards. But that process is in, there's a lot of things that aren't even on the screen that need to be done in the background. For instance, developing the data system first starts with in a development site, then it goes to a test site so we can test internally, and finally it will go to a production site so it's available to you all and to Kate and Crystal. There's a number of things that have to be done on the between the programmers and the IT staff to make all that work, and we've got those processes laid out so that when we're ready to roll it out into production, we're ready to go at that point. Let's see, I think that's all I had. Oh, the other thing that we're going to plan to do is create some live recordings or live training sessions for how to use the data entry system. Again, you're going to see here in just a second the training manual that Patty's been putting together, which is a nice online, basically a manual that you can go to and if you have questions on how the system works, where you input data, those sorts of things. But we'll also plan to hold some live sessions that will also be recorded, and so they can be viewed for future use. To take you through the system and show you how it works, and to show you where errors will occur if you're putting in ranges that are or values that are out of range. So that will be something that we'll get to as we roll out the system.
Thanks, Mike. So Patty, you are currently up, and we can see your messages in the chat box. Go ahead.
Oh, okay. Sorry about that. Just want to make sure that we can get back on time. So, hello, everyone. As Mike mentioned, we are developing basically an online user's manual so that you can come here at any time and find answers to your questions and be able to have this as a resource as you enter data into your system. We're showing this to you as a way to help you visualize the system, and so you can start seeing what it's made of. So I just wanted to review with you that on the left-hand side here is sort of the table of contents of the manual. And we have getting started, so I'm going to go over that here shortly. On the workbench, which will be primarily your home site for the data entry system, and then we'll go over editing site level information, which will be uploading documents, starting PDSA cycles, baseline data, etc. Then we have information on how to enter the baseline data, entering and submitting records, PDSA cycles, which is how to start a PDSA cycle, choose the key drivers, etc. The bundles and interventions, which is where probably that survey that Mike showed you will live. And then the dashboards and reports is where we will give information on how to access the dashboards. So Crystal, if you'll move to the next slide. Just wanted to remind you, we had showed you some of these mock-ups of the dashboards in the earlier learning session, but these will be available to those who have the access to the system, those data stewards for which we have accounts set up, and we will have aggregate data and some run charts and quality metrics to help you understand what's happening with your data and if the policies and procedures that you're implementing are working. And for example, you can see in this that there is dosing errors reduced percentage up there, as Kate mentioned, was calculated on the back end. So you'll be able to see some information on the metrics related to, in this example, weight in kilograms. So next slide. Okay, so we'll also host the data dictionary here, as well as the frequently asked questions. This other two sections, we're hoping to really make this into a collaborative, which are troubleshooting articles and troubleshooting. One is a place to submit questions that you have that you weren't able to find in the online manual to the technical support team, and then we will review those and post the answers online. But we also hope to be able to let you ask questions of your colleagues and related to the data entry system and the process, so that we really can become collaborative. So those two areas will allow you to report and also to review existing questions. And then finally, on the contact information will be listed support information for the data entry system, which will mainly consist of one primary support email and contact information like a phone number. And then those requests as they come in will be triaged, and if there's anything that needs to be raised to the level of a IT management, we will get that to them so that we can get that information or questions answered for you. So Crystal, next screen. So I just wanted to point out that underneath the table of contents in this online user manual will be those that have the little caret sign next to it there, like getting started. There are subtopics such as system requirements, etc. So next slide. So I wanted to point this out because this is very important and something that you can get started on now, which is that there are specific data entry system requirements, and they are that you have the latest version of one of these three browsers installed on your computer, and that is Microsoft Edge, Google Chrome, or Mozilla Firefox. And keep in mind that this will not run in older versions of Internet Explorer. Internet Explorer is basically becoming obsolete on the Microsoft support side. Okay, next slide. So we wanted to give you a couple tasks. So task one is to complete the system requirements for the data entry software. So ask on your side, on our data entry computers, do we have the newest version of Microsoft Edge, Chrome, or Fox installed? And if not, you'll need to contact your hospital IT department to have them install one of these browsers. So we're giving you this task now because depending on IT departments and how overwhelmed they are, this could take some time. So if you want to be ready for the January launch, we really encourage you to start now to make sure that you have these latest browsers on the computers of those who will be entering data. Next slide. Our second task for you, as was mentioned by Mike, is for you to get us those data stewards or user accounts, and you will need to complete the survey, which was mentioned earlier, called the environmental scan, and in the chat box is a link to that scan. So keep that in mind, and we really encourage you to do that as soon as possible, again, because that takes time. So these are the individuals who will have access to enter data, upload documents, set PDSA cycles, and access dashboards. And remember, each site is allowed 2 individuals. So we really encourage you to get that survey completed so that NEDART can start making those accounts. Thanks, Crystal.
Thank you, Patty. That's amazing just for folks to be able to see. I think it's really exciting. I just wanted to add one quick point regarding privacy. So what Patty shared in terms of dashboards, remember that no other site will be able to see your specific site's performance. Only aggregate performance metrics will be shared. And then the last thing is just from a team standpoint, what she showed was just participation, and that's really so training sites can see that whether their affiliates are entering charts or how they're doing in terms of engagement. So it's just intended so that those training sites will be able to support those affiliates if they're having issues with the data entry and things of that sort. So just wanted to clarify that on privacy. Nobody will see your site-specific performance. All right, Crystal, back to you.
Okay, Diana. Are you ready to introduce our speakers today?
I am ready to introduce our speakers. I think for those of us who've been involved with this particular collaborative, one of the most exciting things from our perspective is to actually see all of the things we've been talking about come together by the various teams. So today, this section of the Learning Collaborative hopefully will be helpful to everyone because one of the major goals of collaboratives is to share processes amongst ourselves so that we can accelerate the actual process of implementation of change strategies. So our learning session today will now take a move into some of our teams, and these teams will be focusing in on sharing some information about their teams, specifically their members, some of the characteristics of the hospitals that are working in the team, progress to date, challenges that they have encountered thus far, and strategies that they've utilized to overcome some of these challenges. So today we have Olivia Cullen from Mocan Rocks. Olivia is from Missouri. She's on the west side of the state in Kansas City, a Kansas City Children's Hospital. She's a transport nurse over there. And she and the Kansas City Mercy folks are trainers for hospitals over in the state of Kansas. So this is unique in that she's reaching across borders. They are not located in one, the team is not all in one state. After Olivia, we will have Erica speaking, and Erica is from Whisper, or the Wisconsin team. Her team's a little unique in that their organization is very different and very specific to Wisconsin. Erica is the EMSC manager in Wisconsin, and she'll talk about a little bit about what her involvement has been and support to the Whisper team. Next, Angela Graves, who is with the Providence Hospital Network, will be talking about their progress and some of their challenges and pearls of wisdom that they've gathered having worked with hospitals within a specific network. Our last presenter is Rachel Ford, and she's from the Oregon Pediatric Readiness Program. Rachel is also the EMSC manager for the state of Oregon, and she has worked very closely with the folks from the Oregon Health Sciences University, and she has a multitude of folks who are functioning as trainers. So she will talk about her state and this particular collaborative. I'm going to encourage everyone to enter their questions. Should they have questions as the presenters speak, into the chat box. We're hoping to have time for discussion.
From the part I need.
If Eddie, I think you're online. Your mic's still on. And if you would enter your comments into the chat box or questions, then hopefully we'll have time towards the end to share or discuss those. Otherwise, we'll be able to get back to the individual speakers with your information. You'll see their contact information. So, Olivia, you want to get started? And I think Crystal's going to advance slides, it sounds like.
Yeah.
Sure. Can you hear me all right?
Yes.
Yes, ma'am.
All right. So thank you for the introduction. I'm Olivia. I'm, like you said, from Missouri, but most of our training sites are in Kansas. I'm actually a respiratory therapist and the quality coordinator for our transport department. So I don't actually work in our ER, but I can touch a little bit more on that later. Next slide. So our team includes Sherry McCool. She's our director here in the transport department. Myself, Delia Arnold, who is the assistant director of the transfer center. We work closely with them. Her office is right next door to mine. We pulled in a little bit later into the collaborative because she's our expert on disaster preparedness. So we decided it'd be nice to just have a couple of different people to reach out to for resources right here in our facility if we needed them. Heather Scruton is our assistant director of EMS relations. So she's really great and already has a lot of relationships built with outside hospitals and can help us with a lot of that work. Tracy Cleary is our EMSC program coordinator in Kansas. So she's really been helpful to have on board and to have that relationship with. She's been able to help us with our relationships with our Kansas hospitals, provide a lot of education for both us and our sites, and really encourage participation on both sides, ours and the Kansas hospitals, and kind of bridge that gap between us and give us all kinds of good insight. And then just Children's Mercy Hospital is the name of our facility here in Kansas City, Missouri. We have a hospital in Kansas, but our main site is in Missouri, so right on the border. All 10 of our sites, like we said, are in Kansas. We've got McPherson, Norton, Atchison, Hayes, Ransom, Russell, Shawnee Mission, Smith County, Trego, and Via Christi. We've had a couple of spots where we've had turnover. Some has gone really smoothly and really well, and others we're still working on, where people have moved out of their roles and new people have come into the collaborative, and just trying to get them caught up has been fairly simple. So we've been able to accomplish that pretty well, I think. Slide. So most of our hospitals are in rural areas. About half of them are critical access, and most of them see less than 5 pediatric patients a day. Some of them as few as no patients, just a couple of pediatric patients every other day or so. And then the other handful of them see 6 to 13 a day. Our average PEDS readiness score is 60 whenever you take the average of all of them, with the lowest being in the 20s and our highest being in the 90s, pretty close to 100%. So we've definitely got a wide range of different facilities to learn from and grow with. Our gaps in PED readiness scores, really the only thing that stands out is that we only have one hospital that's prepared for disaster. Otherwise, it's really a toss-up between who all is doing already prepared in what bundle. So our one team that's prepared in disaster is going to move on to the do a vitals bundle, because they don't have a lot of policies in place for reaching out to the physician with certain vitals on PEDS patients. So then there's only one team that's going to work on disaster that has completed all of the other, successfully doing all of the other bundle variables. So I think that's it for that slide. So one of our biggest things we've done is, way back months ago, we set a team meeting that we're doing every month. We meet on the 3rd Tuesday of every month. And over the last 2 months or so, we haven't had a lot to go over. Everyone's been participating in learning sessions, and they've pretty much got a lot of their questions down. But we've found that it's been really important to still hold those meetings, because otherwise we start to drift apart. That line of communication starts to shut down, and then you don't learn as much from each other, which is obviously the goal. So we're meeting, we're talking. We really have been stressing communication via email too, because that seems to be the best way to talk to everyone and just kind of get an idea of where they stand, what they can be working on, and even talking about things that we can help each other with that aren't specific to bundles, just keeping that line of communication. So our teams, they're working on bundles, and they've begun to work on their internal teams. A lot of them I've talked to have stated that they're ready and they have their teams. They just need to complete their environmental scan and declare their data stewards via the REDCap surveys. So right now that's what we're really pushing to get people to complete. So our main challenges, obviously our biggest one is distance. Even though we're on the very border of Missouri into Kansas, a lot of our sites are clear over to the west side of the Kansas border. So visiting in person is really difficult to do, especially with everyone's crazy busy schedules. So one of the things we've done to work around that is we've asked every site to give us their best way of communication for webcams. So not everyone has access to Skype or, you know, these various different outlets. So we have made an attempt, since we have a more robust IT department here at our hospital, to be able to use a varying different sites for whatever our teams need to use at their facility. And then moving forward, we'll be able to do that. A lot of times we can just do conference calls, but once we get into a lot of data and we want to be able to look at charts and graphs together and do some face-to-face work, that'll really come in handy. Another challenge that we've had is that all of our team members here at Children's are in my department, in the transport department. So getting that connection with our emergency department to collect data and policies and procedures was a little rough taking off, but we found that we can really get a line of communication open with them too, and that's been really helpful for us. And then working with our outside hospitals. They've got all kinds of ideas for us. Next. And then communication. Like I said before, I think that it's just really, really important to talk to people. I've found that, especially through the DUA process, some teams have kind of started to fall off. I think they're a little worried, like, are they going to ask again about our DUA and other things we're working on? And I just try to stay really open with them. We've even had a hard time with our DUA, so I let them know how it's going on our end, what kind of difficulties we're having, and I think that they really appreciate that, because then they can see that if they're struggling with something, they're not the only ones. And then even on those third Tuesday of the month meetings, being able to talk to each other and seeing what struggles they're having and communicate that way has really been helpful. So I would just encourage everyone to keep their line of communication open. And that's it, unless you got questions for me.
Thank you so much. If you have questions, please enter into the chat box. Just because of where we are with time, I think we're going to move on to our Wisconsin group. So, Erica, would you like to go ahead?
Erica, are you on mute?
Hello? Can you hear me now?
We got you now.
Okay, great. Thank you. All right, well, thanks for having me. I represent Wisconsin Pediatric Readiness, the WHISPER team, and WHISPER is our catchy abbreviation. Our team members include Dr. Michael Kim, Dr. Lauren Brown, Ben Ethan, Matt Pincinels, myself, and 14 pediatric champions. And as Diana mentioned, our structure is a little bit different. We have 14 affiliate sites that are spread across Wisconsin, and the Children's Health Alliance of Wisconsin, which manages the Wisconsin EMSC State Partnership Program, actually serves as the WHISPER training site. So as the Wisconsin EMSC State Partnership Program Manager, I've really been able to take on a lot of the administrative tasks for this project, things like scheduling site visits, following up with our pediatric champions about DUA status, and scheduling and organizing our quarterly team meetings. And that's really freed up our 4 subject matter expert trainers. Again, that's Michael Kim, Lauren Brown, Ben Ethan, and Matt Pincinels to really focus on using their clinical expertise and providing assistance to the affiliate sites. So it's really kind of offloaded a lot of that more administrative work. They conducted their site visits in person whenever it was possible. Next slide, please. And we have 14 affiliate sites, which we divided into 2 groups of 7. This is our affiliate sites for WHISPER 1. They include Crossing Rivers, Southwest Health, Unity Point, Meriter, Ashland Memorial, Mile Bluff, Sauk Prairie Healthcare, and Divine Savior Healthcare. Next slide, please. And WHISPER 2 includes Howard Young Medical Center, Wheaton Franciscan Franklin, Waupun Memorial, Mercy Health Walworth, Mercy Health Janesville, Aurora Sheboygan, and Marshfield Medical Center. Next slide, please. So the map on the right side of the screen shows the state of Wisconsin and color coding for Whisper 1 and Whisper 2. And in terms of affiliate characteristics, we have out of our 14 affiliate sites, 5 are critical access hospitals. We have a mix of rural and urban hospitals. We've got some clustered around the Madison area, some clustered around the Milwaukee area, which are the bigger urban centers. And then as you can see from the map, we have a smattering of hospitals that are participating across the state. And our hospital sizes range from 25 beds to 500 beds. And in terms of pediatric volume, they include low, medium, and medium-high pediatric volume. In terms of their selection for intervention bundles, they really follow some of the gaps that we noticed with the pediatric readiness assessment. So the most popular intervention bundles that our affiliate sites are discussing starting with include abnormal vitals and weight and kilos. We have, I believe, 2 sites that are considering working on disaster planning as well. Next slide. Thank you. So some of our strategies for strengthening at the local QI teams have included our quarterly team meetings. So our Wisconsin Whisper team meets once every quarter. As much as possible, we try to keep these meetings interactive because they are all occurring virtually. We use the poll features, the chat features, and the hand-raising features in our meetings as much as possible. And it's been very great to have Crystal Bartley, who is our EIIC contact, to attend our meetings when she's able. It's really been terrific. It's great to have access to Crystal, and when our affiliate sites have questions, to have kind of that smaller group environment where they can get some real-time support. Several of our affiliate sites have also started to form internal teams. They've started to meet regularly to begin discussing their key drivers and their potential change strategies. And in addition, they have provided presentations on PRQC at their staff meetings and other education events. And all of this has really led to more support for pediatric initiatives, even beyond the emergency department setting, and development of some of those new initiatives. Next slide, please. We've been hearing, some of the challenges that we've experienced have included turnover of our pediatric champions. So to remedy that, we've really just been trying to keep our contact lists as updated as possible. I maintain a spreadsheet of all of the contacts for our team that we share online via Box. Executing DUAs has also been a challenge. We recognize there's lots of administrative steps our affiliate sites have to get through to make it happen. So we've really been doing frequent follow-up, and I've been able to use my role as EMSC State Partnership Program Manager to dedicate time to reaching out and contacting NEDARC and EIIC to check on statuses of those DUAs. And also in terms of participation for virtual meetings such as the learning sessions and our quarterly meetings, I think clinical schedules have been a challenge for our team all around, just the nature of their jobs. So as much as possible, I try to pepper folks with lots of reminders. I send reminder emails before the learning sessions to make sure all the affiliate sites are aware, and send some reminder emails afterwards to share some of the checklist items as well as links to the recorded meetings. Next slide. So as pearls of wisdom, as far as the DUAs, follow up. Right now we're at 9 out of our 14 hospitals with fully executed DUAs. So we're continuing to make progress on that. The learning sessions are really key. I know there's so much valuable information that are shared on these sessions, so sending out reminders and following up with the affiliate sites after the learning sessions has been helpful, and offering our virtual quarterly meetings I think has been really important to forming our team. All right, that is all I have to share. I'm happy to answer questions by the chat box or by email too. Thank you.
Thanks so much, Erica. Angela Graves from the Providence Network will be speaking next. So I'm going to let you go, Angela, because we're running a little behind. So
okay, I can speak quickly.
Thank you.
Hi, this is Angela, and I'd like to introduce you all to the Wrangler for Kids. That's our otherwise known as Team 13. On the left, you see a picture of Wrangler, who is our mascot. He is an emotional support dog, which is led by the certified child life specialist, and he actually roams around in the child's emergency department at St. Vincent's. And we thought he was a unique resource that we have available for our pediatric patients, so we thought it was appropriate that we name our team after him. Next slide. Our members are Leslie Zimkish. She's the clinical manager for St. Vincent's, which is where the children's ED is. That's one of our training sites. And Dr. Alejandro Kitsis is also a physician at St. Vincent's. My role is I'm the ED manager for basically quality and education throughout the Oregon region. So I help all the EDs kind of get on board and kind of spread the education and the information that we have for PRQC to all of our champions. And then Rachel Ford is our program coordinator for the EMSC, and she has been very helpful in being a liaison between Team 13 and 14. We're both in the Portland metro area, and so it's been great being able to work with Team 14 as well. Rachel kind of keeps us all in line, and she's also extended an invite to the EMSC meeting so that we can update them on the PRQC work that we've been doing. Our team is kind of unique in that we are all within the Providence organization. We're all based in Oregon and within driving distance. Some of them are, I think the longest drive is like 2 hours from where my office is. So it's very easy that way to kind of pop in and see how each ER is doing. And we can go ahead to the next slide. This is a list of our champions. We have also had some change in our champions. Nicolia, unfortunately, will be leaving, but we have Nicole Hudson, who is excellent and can help us with Willamette Falls. And then you can see the rest of the amazing champions that we have. They are all just really highly motivated and passionate about PEDS. Next slide. So this is some information about our different training facility and our different affiliates. You can see that the ERs are all different sizes. We have 2 critical access hospitals, and you can see the PEDS volume that we had in 2017 in each of the different ministries. We call each hospital a ministry here at Providence. And there's some information there which kind of makes every hospital a little bit different. We are all doing intervention bundles 1 and 2. We felt like that was a really good place to start. Our average PR scores were also around 60, so we felt like getting the basics down was the best place to start. Next slide. So some common gaps that we found is some of our scales we're still in the pound option, so we're still weighing in pounds. So that was kind of an easy, kind of low-hanging fruit that all of our champions can start correcting. Epic is allowing pound and kilogram charting, so we're working on that. We found that the expectation of a complete set of vital signs was different in each ED, so we're working on a definition of what exactly a complete set of vital signs means. We're also lacking a dedicated pediatric nurse coordinator in the organization, and that is something I know Leslie and I would love to see, and hoping that we can make that happen at some point. And then we're also found that we have a lack of pediatric care review process within our organization, and so I think that's something that this collaborative will really help shed a light on. Go ahead. We have a team meeting, which is every second Wednesday of the month. One of the things that we found that it was a little, when we first started, we just added an extra hour onto the already established regional PEDS meeting. And that was a little bit confusing because then on everybody's calendar it looked like it was a 3-hour meeting. So we realized that it worked, I think it's going to work better. We're trying it out, that we'll have our own independent meeting for the PRQC instead of tagging it onto that last hour of the regional meeting. We asked the managers to find champions for each of their departments. The managers have been extremely supportive and picked, from what I see, some excellent champions. Some of our affiliate EDs have established teams and just kind of the independent teams and are already meeting regularly. We decided that we should start with weights and triage first. That way they can, that's kind of the, from our perspective, the easiest of the bundles. And so they can start out with having some wins immediately and just kind of build that momentum within their departments. And then some of our ministries have clinical ladder within their union contracts. So they are able to use some of these actions as clinical ladder projects, which helps as well. Go ahead. We are also experiencing some changes in leadership. We have 2 managers that have taken new positions within our organization. One moved to California, and one will be retiring in 2019. And we also have 2 new assistant nurse managers. So I've been trying to keep everybody updated, and it is challenging, but the level of motivation is so high that it really has been fairly easy. One of the things we realized right off is a lot of our engineers do not know how to fix our scales. And so Leslie found the name of one gentleman who knew how to do that, and we've been sending his name out throughout the whole region so that everybody can get on board with that. Some real basic things. Some of our champions did not have access to Skype for Business, so we were able to get them hooked up so they're able to join our meetings. Some of the champions had never led a process improvement initiative before, so I've met with some of them, and we went over the fishbone diagram and PDSA cycles and things like that to help them in their leadership. And then some of the people have had difficulty watching the recordings of meetings that have been missed, and I believe everybody is on this link, so I think we had some success today. Like I said, we've been meeting with new managers individually. We've distributed the name of the engineer who's knowledgeable about the scales, and I think the rest I've already gone over. Go ahead. So tips for success: meet regularly, even if it doesn't, like Olivia was saying, even if it doesn't feel like there's a lot going on, just kind of doing those regular check-ins, I think, keeps people engaged. And I think it's really important to help the champions break things down into small, actionable items to prevent them from feeling overwhelmed, because this is a lot of information all at once. And I think just giving them kind of lists of, okay, this is what's next. And right now we're working on our environmental scans. And then to gain the support from the managers, I believe, is just so important, and luckily that is abundant here. Okay. Any questions?
We're going to ask that folks put their questions into the chat box if they have them for Angela. Let's move on to our friend Rachel from the Oregon Pediatric Readiness Program.
Good morning, everybody. Can you hear me?
Yep, doing good,
okay.
Rachel.
Perfect. All right, you can go to the next slide. So I'm thankful to be working with a large team of folks, both from Dornbecker Children's Hospital and Randall Children's Hospital. As you can see, there's several members from each of those hospitals and myself that make up the training team for Team 14. Next slide. We have 11 affiliate sites. We had 12, but one had to step down just due to conflicting priorities, but we still have 11 sites. They span over 2 different states, Washington and Oregon, and they're from all over the state. We wanted to be sure we had a good group of folks that represented not just the Portland area, but all over our state. Next slide. 5 of those hospitals are critical access hospitals, 6 are urban. They see anywhere between 1,000 and 16,000 pediatric patients per year. Most of our sites have selected abnormal vitals as their bundle. Some have selected weight and kilos, and we have a few that have selected interfacility. We don't have anybody that's working on the disaster bundle, but I know that there are sites that are interested in that perhaps in the future. Next slide. We started monthly team meetings pretty early on. For 2018, they're set up for the 3rd Monday of the month. For 2019, we're requesting input from our sites to see if that meeting date and time works for them or if we need to move it. We'd like to be inclusive and make sure that we're catching as many hospitals as we can for those calls. We try to provide regular updates and encourage participation during the meetings. We've provided the PRQC calendars for 2018 and 19, which I think is helpful, and just making sure that the tools and informational resources are available. We've set up our own Dropbox site where we've gathered different tools and resources. As we went through and did all the site visits for each of the hospitals, there were some requests from various hospitals, and we wanted to make sure that those were available to all of our participating hospitals. And then each hospital has built out their own on-site teams, and a lot of them are just ready to start collecting data. We do have a few that are still working on those data use agreements, and those have proved to be a little bit of a challenge for some of our hospitals. Next slide. So like I said, our biggest challenges have been the data use agreements, and then a few of our hospitals have had trouble accessing the PRQC information on the box site from EIAC. But I know that they've been working on that, and hopefully we'll have a new way to access the info soon. And then also been working with Eddie to work through those data use agreements. Next slide. That's it.
Thank you so much, everybody, for presenting. It's great to hear all of the progress that is occurring, and hopefully that gives a few examples and strategies for the rest of the teams as they think about where next to go. Crystal, I think it's your turn again.
Yes. So what we want to do is give you this 14-month game plan of what to expect from the month of November through December of next year. So for the months of November and December, remember this is your last learning session for 2018. Our next session won't be until January the 15th. So for the months of November and December, we want you to work on completing your administrative tasks. So go ahead and establish your data use agreements if you have not done so already. Identify your data and QI stewards. Complete your environmental scan. You can go ahead and start working on those IHI modules. Remember, every hospital has been given access to 2 slots for the education platform, and we can send you the login information for that. And you'll be declaring your intervention bundles. As Kate mentioned earlier, if you're working on Bundle 1, you can go ahead and start mapping those variables in your EMR platform using that paper survey, and then work on defining your sampling strategy. For the month of January, that's when you're going to start entering your baseline data. so you can collect that data in the month of January or use data prior to that. This is when you'll mobilize your sampling plan. So if you decide to go with every 3 pediatric patients, or if you decide to go with every 5, or you start stratifying the shifts in which you're collecting data, you'll implement that during the month of January. Using your baseline data, you'll define your SMART aim statement for your first PDSA cycle, and then you'll identify your change strategies based on those core key drivers that are in the implementation in the intervention bundles. From February through September 2019, this is when you're going to be rolling out your PDSA cycles. We ask that you have more than one, and we're sure that most sites will go through about 3 to 4 over time, depending on their aim statement. As you heard today, we will have updates from some teams about their progress that they'll be sharing at learning sessions. The PRQC admin team will be showing you aggregate data so we can see sort of how the collaborative is progressing for our global aims. And there will be the sharing of best practices specific to each intervention bundle. In October through November 2019, we will start working on sustainability planning. So really, how are you going to hardwire those improvements that you've gained from January 2019 through that fall? We'll work with you to put together some of your final team reports, and we're asking that you review your improvement efforts with your key hospital stakeholders, primarily to let them see the progress that you've made and discuss what your next steps should be. And then lastly, in December, there will be final reporting. So we will have a series of evaluations regarding the PRQC and your experiences. We'll be working to disseminate some of these best practices that you will have established for the particular intervention bundles. And then HRSA will be sending out those acknowledgement letters saying that your hospital spent the last year and a half working on improvement efforts specifically for pediatric patients. And then you'll submit a final summary of your improvement efforts. So this is the timeline or game plan for the next 14 months. We realize that a lot of hospitals have completed those tasks for November and December. So if you are working on Bundle 1, then you can go ahead and start collecting that baseline data, and that paper survey is currently in box under the folder that says data. And what we can do is work to make sure that you guys all get a copy of that soon. Last but not least, if you are requesting maintenance of certification credit, the project has been loaded for the American Board of Pediatrics. We're still waiting to get PRQC loaded into the medical specialties sector. I'll be sending out instructions on how you can generate your attestation form. So all of our trainers, you're definitely going to receive 25 points for your participation this year. And we'll work with the champions to also see if they've fulfilled the requirements to receive credit this year as well. The last thing, remember that CME CNE credit is just not for the trainers and the champions, but we are offering it for any member of your care team. So that's a carrot to really get them involved. Be sure to include them on the invites for your learning sessions, and remember to submit your credit request. The task list has not changed, so if you haven't completed your site visit with your training site, please go ahead and do that. The Site Visit 1 survey is very different than the environmental scan, but it asks more demographics information about your hospital. So you'll notice during today's updates, the hospitals were able to say the number of beds that are associated, the number of patients they see, or their volumes. So that sort of information is in the Site Visit 1 survey. Remember, we are using the Pediatric Ready Assessment as your baseline, so don't forget to complete that as soon as possible because the portal will be closing soon. You've heard a lot about data use agreements, so remember, let us know if you need to reach Eddie. Remember, 2 QI champions per site. They will have full access to all of the online education modules. You'll have access to 2 data stewards, which means that your hospital will have 2 accounts. Those individuals will be able to enter data as well as generate reports about the site-specific data for each quality measure for that intervention bundle. Don't forget to complete your environmental scan, and all of these steps have been outlined in the implementation toolkit. And please let us know if you have any physicians that are interested in seeking MOC credit for this year, especially those that are expiring mid-December. All of the content from today's session will be posted in Box, so you'll find a copy of the learning session, the recording, the slide deck, and then under the data folder you will find the paper version for Bundle 1. Upcoming events, remember the learning session is scheduled for January 15th. We'll send out reminders because we know that you guys are getting ready for the holidays. Trainers, we want to see you in Austin, so we'll be sending very detailed information about how to schedule your travel. Terry will be sending that around Thanksgiving, so be on the lookout for that. Continue to attend your monthly meetings, and then we will be working on our post checks for the remainder of this year. I'd like to thank everyone for joining today's session. We appreciate all the time that you have, and don't forget, enjoy the holidays, and we will see you back in January.
Thank you, everyone, and sorry to go a little bit long today. If you didn't get your questions answered, please feel free to send us an email. And thanks so much to all of our fabulous presenters today and for all of you for joining us. And we'll be in touch and for sure see you in 2019 on the January 15th call.